So I imagine you've been seeing these all days. They were very clear on wanting disclosure requirements. I didn't actually understand all the stuff at the bottom, but they said we had to have it, so that's under blah, blah, blah. You've probably read it already. It's the same thing I cut and paste in from that were sent to me. You need learning outcomes. I'm hoping at the end of this, maybe you'll learn something about POTS that you didn't know, and if not, I'm sorry. So I'm going to start with a case. This is a case that I've used for a couple of years, but it's fairly illustrative of what I think is a fairly prototypic POTS patient with a myriad of symptoms. So this is a patient from when I was still working in Nashville. The patient was a 26-year-old single white female. Although it's cliche, she actually did work in the music industry. It turns out Disney had a music label. Who knew? And so she was well until she wasn't, right? So she got sick, diagnosed with a pneumonia, got put on inhalers initially, and then started developing spells of tachycardia. So she ended up getting referred to a cardiologist, not a neurologist, a cardiologist, presumably because of the tachycardia. And the first one she saw wanted to stick catheters in her and burn something and offered to do an ablation. She wasn't that excited about that, saw someone else who ended up tilting her. And we'll get to her orthostatic vitals in a moment. But importantly, in addition to the tachycardia, the orthostatic tachycardia, she had a bunch of other symptoms that are really typical and necessary for the diagnosis. So she had lightheadedness or presyncope on standing, chest pains, not sort of the ischemic bear hug pains, but more sharp stabbing chest pains on standing. Problems with mental clouding or brain fog, concentration, and just severe fatigue. So this, when she came to us, we did a set of orthostatic vitals. We typically didn't tilt people for the diagnosis at Vanderbilt. And you can see that, supine, things were okay, heart rate is 73, blood pressure was 103. Within a minute of standing, her heart rate jumped up over 30 points. And by 5 minutes, her heart rate had jumped up almost 50 points. Right, so she clearly had excessive orthostatic tachycardia. Her blood pressure went up a little bit. It didn't drop, certainly. So we'll try and address a couple of sort of just high-level issues. So the first question is what is POTS? We talk about it all the time. One of the challenges is that, based on referrals anyway, I think sometimes people have sort of a broader definition than perhaps exists. So importantly, POTS requires a couple of things. It requires abnormal hemodynamics, and it requires symptoms. You can't diagnose POTS just based on hemodynamics. So the hemodynamics is an excessive orthostatic tachycardia. And we can quibble about what excessive is. The truth is that the normal physiologic orthostatic tachycardia is linear and decreases with age. But let's face it, that's actually way too complicated for clinic. So we have a number, right? And the number that was used, that was defined by Phil Lowe back in the early 90s with Ron Schondorf, was an increase in heart rate of greater than 30 beats per minute. Now, an increase of greater than 30 beats per minute in a 50-year-old is a lot more impressive than an increase of greater than 30 in a 20-year-old. And I think when seeing patients, you have to keep that clinical context in mind. It gets even worse when you get to teenagers or pre-teenagers. And based on some work done, again at Mayo, by Wolfgang Singer, where they took healthy kids and tilted them, they found that a whole lot of them actually met the criteria that were perfectly well otherwise, met the heart rate criteria. So they redefined the pediatric criteria, heart rate criterion, to be at least over 40 beats a minute. But even that's not the entire truth, because that's probably okay, a reasonable threshold for an 18-year-old, but a 10, 11, or 12-year-old physiologically probably has a higher heart rate than that, a heart rate increase, right? So just keep in mind, in the mind of context. This, importantly, is in the absence of orthostatic hypotension. At last year's meeting, I had a patient arguing with me about why she couldn't have POTS and orthostatic hypotension, and it's a semantic issue. It's one of definition, right? We have a separate name for patients with orthostatic hypotension. It's orthostatic hypotension, right? And then there are other related disorders, right? The idea of POTS is it's orthostatic tachycardia that's not a reflex response to the orthostatic hypotension, so it's different. And importantly, gotta have symptoms, right? Otherwise you have POT, not the marijuana stuff, just the tachycardia stuff, right? The S in POTS is syndrome. That's a clinical presentation. So you have to have a constellation of symptoms, and we'll get into some of the detailed ones as to what they are, that are worse when you're upright and better when you're lying down, right? It's an orthostatic disorder. Some of these may be due to sympathetic activation. Some of them may be due to brain blood flow. We don't actually know what a lot of them are due to. That's okay. And not all the symptoms have to be orthostatic, but if none of them are, then it's not really an orthostatic syndrome we're dealing with. And it should be chronic, and we can quibble over whether that means you have it for 6 months, you have it for 3 months. I've seen both. The truth is, we use 6, but I'm not sure I saw a lot of patients that got better between 3 and 6 months. But the reason we have that there is that there are patients that get the flu or a bad cold that if you assess them fairly acutely, they would meet the other criteria for POTS, right? But they don't have POTS, they have the flu. And most people get better. If you feel like doing an experiment on yourself next time you get the flu, measure your orthostatic vitals. I'm willing to bet it'll be elevated, right? But in 2 or 3 days, it'll probably start getting better. The difference in these patients are that they're well beyond the acute phase and they don't get better, right? So it's context and timing. This slide lists common symptoms. It's far from an exhaustive list. I've chosen to break it down into symptoms that sound cardiac-ish and symptoms that don't. On the top are symptoms that tend to be worse with upright posture in black, and then the symptoms in blue on the bottom aren't necessarily positional, right? So the cardiac ones are the rapid heartbeat, the palpitation, chest discomfort, shortness of breath, lightheadedness. These patients almost all have exercise intolerance as a part of their presentation. But they also have other problems, like our initial patient. Mental clouding was a big complaint. Brain fog, not thinking clearly. Headaches, I'd say 90% of patients have headaches. Many are diagnosed as having migraine headaches. I'm not smart enough to tell you if that's true or not, right? If someone else said that it's a migraine as opposed to another type of headache, I'll take their word for it. But they do have headaches, and that's actually can be a disabling part of their presentation. A lot have nausea. Some describe an inner shaking or tremulousness that occurs that can be worse on standing, actually, usually worse on standing. Everyone is fatigued. Okay, almost everyone, there may be 1 or 2 people that aren't, but almost everyone is fatigued with POTS. Only about half, a little less than half when we looked at the Vanderbilt series met CDC criteria for chronic fatigue syndrome, but everyone is fatigued, it's universal. And most have sleep complaints, although probably more in the insomnia realm. When we looked at this, very few had sleep apnea or other sort of more serious objective sleep disorders. This slide just illustrates tilt test patterns for POTS patient on the left and control subject on the right. Heart rate on top, blood pressure in the middle, the tilt angle, you see the table went up here and back down here. So certainly the blood pressures may look a little different, the pattern between the two, but they're not numerically different. If you average it out, they're about the same. It's a little spikier, and that may be relevant in terms of the POTS, but you can't say the blood pressure's lower anyway. The control subject, the heart rate went up on standing. It's important to know that a heart rate increase is not abnormal. That is physiologic. That's normal. The issue is that this POTS patient is an overachiever, right? While 15 is good, they thought 45 was better, right? I mean, be all you can be. So it's an excessive heart rate issue that we have, and that's fairly typical. Early on in my time at Vanderbilt, we had a study, we were looking at something else, we were tilting people, and we assessed symptoms every few minutes with a early version of what we now call the Vanderbilt Orthostatic Symptom Score. We had POTS patients and control subjects, and a couple of interesting things here. The POTS patient, the most interesting thing about the tilt is that actually a higher percentage of the POTS patients completed the 30-minute tilt than the control subjects, right? POTS isn't a fainting disorder primarily. The control subjects, the POTS patients, though, from almost the first minute, told me they were about to faint. And they kept telling me for 30 minutes that they were just about to faint, right? It's a presyncope disorder. They feel faint. That doesn't mean they do faint, right? Some do. A minority overlap with vasovagal syncope, but it's not a fundamental part of POTS. The control subjects would feel well until they didn't, and then they'd faint quickly, and then they drop out, and their symptoms would get better again, right? So different, but the POTS patients have orthostatic intolerance. Doesn't mean they pass out necessarily. Of the POTS patients that didn't make it, only half of them fainted. The other half just felt so horrible they said stop. So who's affected? Honestly, there are no good estimates, right? I mean, one of the challenges is we all have to code at the end of clinic to get paid. And I suspect, what code do you guys use for POTS? How many use autonomic disorders, NOS type codes? How many use tachycardia, NOS, that used to be 785 and ICD-9? How many use orthostatic hypotension? right? So there's a smattering for both. Most of you guys don't bill, apparently. But we appreciate your service anyway. Right, but the point is that's the challenge, right? I mean, even in our clinic at Vanderbilt, I suspect each of us used a different code. Because when I was in clinic, the most important thing about the code is that no one came back to me and asked me more questions afterwards, right? I wanted to be done with it and not hear about it again, right? And if it worked, then I kept using it, right? But the challenge then is if you're going back and trying to figure out how many patients there are other tachycardia patients under tachycardia codes and POTS patients under other codes. So it's very difficult to get your arms around that. So a lot of these are based on back-of-the-napkin math estimates. We do know that I think the overwhelming majority are female. Certainly in our studies, often it's well over 90%, but at least a 4 or 5 to 1 ratio female to male. The ages can start younger, can go older, but I'd say the sweet spot is in the women of childbearing age, maybe just a bit over. But in terms of onset, around puberty to sort of 40 is probably the sweet spot of when we see patients starting. It can be older, though. And importantly, it's associated with a huge amount of functional disability, and we'll touch on that as well. So I think many people that have been confronted by POTS patients, especially those that don't see patients very frequently, will sort of get the impression that these patients are nuts. And it's probably an unfair characterization, and I have theories as to why this happens, but it was common enough that we actually did try to assess this at Vanderbilt. And this was a study done by my wife, actually, who's a psychiatrist now, when she was a research fellow at Vanderbilt years ago. And she administered several tools, including a structured evaluation at the time that mapped to DSM-4-TR diagnoses, right? And the bottom line was that the patients may be crazy, but they weren't DSM-4-TR crazy, right? So there was not a higher incidence of major depression or anxiety disorders or panic disorders in the general population. What there was, the one thing that fell out in the different tools was inattention, right? Using the Conners adult ADHD rating scale, what you see is that there's the normal population and the ADHD population with abnormal scores, and the POTS population was in the middle and had significantly higher scores than normal. And so when the patients complain they're not about memory problems, we've actually done more work on this, and there may be some memory problems, but a big part of it may be a concentration problem or an inattention problem and not being able to process that memory. But it's commonly reported, and there are objective findings to support that. Just a word about anxiety. One of the challenges with anxiety is that patients that are anxious get palpitation, get sweaty, get tremulousness. So things that we associate with some of the hyperadrenergic features in POTS are common in anxiety. And if you use rating scales like the Beck Anxiety Inventory, you get points for all of those things. So when you use a tool like the Anxiety Sensitivity Index, which is more a cognitive anxiety-based tool, the POTS patients actually did have more anxiety than the psychiatrically normal population. My wife was very excited to tell me that I did not qualify as psychiatrically normal for the purpose of this study. If you look at the POTS patient scores compared to the general population, it actually was not elevated, right? So there's a little bit of anxiety in the general population. There's not more of it in POTS. Having said that, there are crazy POTS patients out there. Just like there are crazy heart failure patients or crazy diabetic patients. I mean, you're gonna see this across groups, but as a group, it's not associated. One of the challenges is, always sorting out, is the heart rate increase due to anxiety? And there's a very elegant study that some of you are probably aware of, done years ago by Mike Joyner's group at the Mayo Clinic, where they put patients and control subjects into a lower body negative pressure box. So this is basically, think of a coffin from your waist down that they hook up to, a medical suction device. We used to use an Electrolux vacuum cleaner, but an important medical suction device, and you'd suck air out and suck blood into the legs, right? So it simulates standing for research purposes. It simulates the blood pooling, less blood coming back to your heart. And then before putting them in, they put on masked pants. So these are basically, I think initially military pants, but EMSs use it, where you can blow them up and they form a little air tube to try and stabilize your legs if you have a long bone injury. Okay? So what they did in this study is that they did the LBNP with more and more pressure, and the POTS patients on top here, you can see their heart rate is higher to begin with, but got higher at a faster rate than the control subjects. Blood pressure didn't change. Then they did the same thing with the mask pants blown up. And you can see the POTS patients have a higher heart rate to begin with, and there's no change throughout. So if you block the effects of the suction, if you avoid sucking blood into their lower body and away from their heart rates didn't change, right? It wasn't related to the noise or the stress, because the Electrolux makes the same amount of noise, mask pants are not, right? So it very elegantly showed this is a physiologic and not a psychological heart rate increase. We did some work on quality of life scores and sleep in POTS with Kanika Bagai, who's a sleep neurologist at Nashville. This wasn't our data. This is published data using the SF-36, looking at 2 disorders that are associated generally with a shitty quality of life. They're chronic back pain and dialysis patients, end-stage renal disease patients. This is the data from our POTS patients mapped onto that. Okay, so these patients, regardless of what is causing it, the net result is that their quality of life is poor, right? There's a significant functional disability associated with it. The fact that you're here, I suspect you guys know that already, so I'm preaching to the choir, but it's just worth going back to the impact of this disorder, whether we understand it or not, can be great. Half the time I present this, the red dots don't show up, so I'm quite excited. I'm not sure why. So it was originally a sleep study where we looked at quality of life. So we actually took a summary sleep score, a medical outcome study sleep problems index, and regressed that against both the physical health score subscore from the SF-36 on the left and the mental health subscore on the right. And in both cases, about 60% of the variance in score, the variation in the quality of life score, was accounted for by their sleep. Don't know if this is cause or effect. This is a relationship. But if you talk to most patients, they don't sleep well. And when I'm on call or don't sleep well, or because we're doing a study like tonight, my quality of life goes down personally. I can tell you that. Right, so it's worth thinking about. Obviously, the POTS patients were on the worst end of the score than the control subjects, but they all do follow sort of a line, if you want to believe. Okay, so that's the what, but what about the why? So what is actually going on? And the truth is, this is challenging, because I don't think POTS is a thing. POTS is a bunch of things. It's a syndrome, a bunch of things that end up looking sort of similar. So David Robertson has often said that it's the final common pathway of hundreds of genetic and acquired disorders, acquired autonomic and cardiovascular entities. He argues it's a little like diagnosing a fever, right? It's correct that someone has a fever, you can measure it, you can even treat it and make someone somewhat better, but there are lots of different ways of getting to the fever with different underlying causes and different prognoses. It's worth keeping in mind that a POTS diagnosis isn't the end of the diagnostic journey, it's an interim step. Right, and the challenge of the pathophysiology of POTS is like the story of the blind man and the elephant. Do you guys know the story? Right, it's, like a lot of, historical stories. It's very typical. Different cultures around South Asia, around India, claim it. The Jains have a version of the story, the Hindus have a version of the story, the Muslims have a version of the stories. But yet a Brit came, stole it, published it, and took credit for it, Jeffrey Sachs. They have a lot to answer for, those Brits. So it went to 6 men of Hindustan, the Hindu version, to learning much inclined, who went to see the elephant, though all of them were blind, that each by observation might satisfy his mind. They include that the elephant is like a wall, a snake, a spear, a tree, a fan, or rope, depending on where they touch. And that's the challenge with POTS research, is that different people are researching different things that they have the ability to do, and you get different answers, right? But you can put this together in a whole story, but not everyone's able to do everything. That one's me. So this, again, is not an exhaustive list, but there are different pathophysiologic groupings that you've probably heard of. We're not going to talk about them in depth, but mast cell activation is an overlapping disorder, and a few people may be the underlying cause. Partial autonomic neuropathies affecting the lower limbs have been described. Leg blood flow abnormalities have been described by Julian Stewart with high flow and low flow people. Again, this may relate to the partial neuropathy. Many patients are hypovolemic. If you objectively measure their blood volume, it's low, not absent. It's about a can of Coke low. right? Which it seems like it should be easy to fix, but it turns out it's not, because you can't stick the can of Coke just in the blood, right? I mean, you have to finagle it to get it there. There are people that are hyperadrenergic. People like saying, I've heard tons of people say, I have hyperpots. For the life of me, I don't know how they make the diagnosis, because I don't know how to make that diagnosis, right? The reality is these are physiologic concepts that aren't mutually exclusive. They overlap a lot, and it all depends on definition. I'd be very careful when patients come in with those labels. And then a few words about antibodies. So just with neuropathic POTS, just a couple of schematic cartoons. This is described in a New England Journal paper in 2000 by Jiris Jacob, who's now in Tel Aviv. But the idea is that you have neuropathies that may affect the vasculature in the lower limbs, may affect your kidneys, and part of the feedback response is not getting the proper output, so the brain will then start churning out more and more sympathetic nerve traffic. The heart, which isn't affected neuropathically, then gets more input, and you get tachycardia. That's the theory behind that. The original study by Jiris was done with sort of segmental norepinephrine spillover in the legs. The reality is that's a pain in the butt to do, and no one does it. People use QSARTs. People use skin biopsies as a diagnostic tool. The truth is that's a little bit different, right? Those are looking at cholinergic problems and not necessarily looking at sympathetic nerves. But it's the best we can do. There's sympathetic nerves, but not noradrenergic nerves. But best we can do. A hyperadrenergic state, this is usually the easy one to think about, right? You just have your brain's just going to overdrive and people are just really revved up. And truthfully, there are patients like this I've seen. This is a pretty small group, right, that has this without another underlying cause where they just, there's no reason, they just seem really revved up. Not common. The decreased norepinephrine clearance, and some of you may know the story, some of you may not, is fascinating. And it's worth thinking about the norepinephrine synapse for this. So presynaptic terminal, postsynaptic terminal, norepinephrine are the little red dots in the vesicles, and they get released into the synapse. And when they get released, they get taken up, and they get taken up by this transporter called NET, or the norepinephrine transporter. This is part of the justification of the research study we're doing at this meeting. Right? It's an important transporter that clears this. If you block it, then what ends up happening is when you release the norepinephrine, it can't all get taken up, so less of it gets taken up and more of it lingers, right? And more of it then works on your alpha and beta receptors on the other side of the synapse. So you get more bang for your buck. And the net effect is effectively a hyperadrenergic state. You have higher sympathetic tone every time the nerve fires. Okay, so finally, you have POTS. What do you do about it? The investigations, I'm not going to give you a long laundry list of things to do because the reality is that a lot of it has to be based on what patients present with and have. History and physical, with not just POTS actually, with all orthostatic disorders, I think are critical to sort of understanding the journey and listening with a trained ear. Orthostatic vital signs, you can't diagnose orthostatic tachycardia without orthostatic vitals. It's the bottom line. It sounds like a stupid thing to say, but based on the referrals I get without it, clearly it needs to be said more. You can't diagnose orthostatic hypotension either. That's the other one. In everyone, I get at least a CBC and a basic metabolic panel just to make sure there's not gross anemia, something gross electrolyte disturbance that can certainly cause tachycardia and it certainly would not be the underlying problem. After that, there are tests that I would do when you think it should be done. I think autonomic reflex testing can be useful. Probably not every POTS patient needs formal testing, but certainly it may give you an idea if someone is squishing adequately their vessels or someone is more looking like a little bit of autonomic impairment, maybe the partial neuropathy types. It can be helpful. It's not always critical. An echocardiogram I don't think is necessary if you have a good cardiac exam, but you need to make sure that their heart is basically normal. I had a patient referred to me who developed POTS during or in the latter part of her pregnancy, got referred to me postpartum, who actually had a peripartum cardiomyopathy. It did an echo. I'm not sure how it got missed, but did an echo, or EF was around 30%. Right? So she did have orthostatic tachycardia. That's entirely true. Treatment's entirely different. I don't think she would have done well with Florinef. Right? So again, don't miss the obvious. Not everyone needs an echo because of that. Right? If you can examine her and it's normal, it's normal. Blood volume assessments can be useful if you can get it. Right? It can quantify which patients you have to push harder at. The problem is even with that information, it's a difficult thing to treat. Right? But it may help you decide Florinef or not, for example, in some patients, or whether you get more aggressive in other ways. And exercise capacity assessments I found can be useful as well, mainly for serial observations, right? One of the challenges when you see people over and over again is, and you ask them how they're doing, is that, at least in my experience, if they're coming back, they're usually not doing well, and so they'll complain about how horribly they're doing. And it's depressing, right? And sometimes you just want something objective to hang on to point out that either, yeah, they're right, or maybe they're not doing as badly and they're just looking at the world, the half-empty glass part of the world, right? So it can be useful to track progress over time. In terms of treatment, I've sort of broken treatment into 4 large categories, and we'll discuss a couple of the sub-points underneath. But exercise programs are really a mainstay of therapy. It should be discussed every time. Not everyone's going to be able to go whole hog into it, but I think there's pretty good data that it can make a big difference. And in many of my patients, if you can get through the initial portions, which can be very difficult, it becomes an important part of therapy. Not all of therapy necessarily, but a very important part. In terms of the exercise, the best data came from Chi Fu and Ben Levine in Dallas, and this was a schematic of their exercise study published several years ago now. They did a heroic level of evaluation of patients before and after the exercise program. It was a 3-month exercise training program that took 5 or 6 months to complete, right? So they had calendars for 3 months, but if you weren't fit enough to start month 1, you had pre-month ones. And then if you actually didn't religiously stick to the calendar, and we'll get to that, they actually dropped you back a week or 2 in the calendar. So it was common for it to take a few months longer to do, right? But it wasn't a long-term program. And the short version of this is that a relatively short exercise training program increased fitness levels, great. Increased blood volume, had an interest in that. Improved cardiac remodeling, so they did cardiac MRIs and looked at masses and it changed. Normalizes sympathetic activity, so they had MSNA, looked at nerve traffic directly and that improved. Most of these mean nothing to the patients. Importantly, from the patient point of view, it decreased orthostatic tachycardia and improved quality of life. So they looked at SF36, right? So it really was beneficial if you completed the program, and that's the big if, with any exercise training intervention in any disorder. So how do you do it? So this is based on our approach. So there was a little bit of resistance training they wanted, focused on the thigh muscles to build up a muscle reservoir for fluid in the thighs, but mainly this is aerobic reconditioning. So I'll have POTS patients coming and telling me that, well, I do Pilates. And don't get me wrong, I couldn't do Pilates if my life depended on it. If I bent over, I'd land on my head, right? But it's basically core strength and balance issues, and those are great. They're not going to do anything in terms of aerobic reconditioning. So it's not that they can't do the Pilates, but they're not getting points for that in terms of their POTS work. So they need to think about it in terms of aerobic training. They need to do it frequently, and this is one of the issues that was emphasized in the Dallas study. If you actually missed days, either for good reasons or bad, it didn't really matter, you often weren't, they pushed you back on the calendar mainly because you actually regressed fairly quickly at this early stage, right? So it basically, they said 4 times a week. What they mean is every other day, right? You don't need to work out 6 days a week, but you can't sort of give yourself big gaps because it'd be like snakes and ladders where you're falling more than you're winning. You need to get your heart rate up, however little exercise that takes, and keep it up for a sustained period of time. And that's fairly early, that's 30 minutes, and eventually they want to build to 45 to 60 minutes. Okay, so it turns out 6 5-minute segments through the day aren't the same as 30 minutes. And you need to emphasize that to the patients. If they really can't do it and they feel like they're going to pass out, tell them to stop and go back, but fairly quickly they need to build up the time. And when they're actually exercising, most people, when they hear exercise, they think upright things. They think running, treadmills, ellipticals, they're evil, by the way, all upright stuff. And then you're compounding the exercise intolerance with the orthostatic tachycardia. If your heart rate is 150 beats a minute before you turn the treadmill on, you're not going to last very long. So I think one of the most clever things they did is they banned upright exercises initially. Right? So they want you squatted or horizontal. So swimming, rowing machines are actually what they preferred, or swimming, or recumbent cycles. Obviously, you need to know how to swim, otherwise it's called drowning. Not good. Rowing machines, are good for a lot of patients, except the ones to be careful about are the Ehlers-Danlos patients that have had hip dislocations. If every time they push back on the machine, their hip pops out, they won't last very long, right? So you need to find what works. But ultimately but they don't need to go fast. They don't need a lot of resistance. I tell people to turn it right down, right? If they can get the heart rate up with no resistance, great. That's the key. It's not what you put in, it's what the heart rate output is and where it stays. The most important thing is managing expectations. So I told you that everyone got better in terms of quality of life and other stuff by the end of the study, but that doesn't happen right away. It takes often, I said 4 to 5 years, it may even be 5 to 6 weeks before they start noticing improvement. And in that period of time, they're going to feel worse. When the patients tell you that if I exercise, I can't get out of bed for 2 days, they're not lying to you. That is what happens. What you need to do is convince them that, yes, that is what happens, but if they hang in there, that will change. But they have to hang in there longer than they might if they don't know that there's actually light at the end of the tunnel. So in terms of other approaches, we want to target an increase in blood volume. The idea is to increase cardiac preload ultimately. And there are different ways of doing this. There's sort of lots of approaches. We tell people to drink lots of water. We tell people to increase their salt. There's actually very little data on that. We have data from Vanderbilt that it does actually do this. We presented this at the American Autonomic Society. We'll hopefully publish it this year. Well, or next year, soon. Fludrocortisone is sometimes used. Octreotide. I'm not going to present that directly, but I'll say a word about IV saline. So this is, again, old data from Jiris Jacob. You see patients that were tilted 1 hour after placebo, still had a lot of orthostatic tachycardia. Patients that were tilted 1 hour, where they got saline for that hour, their heart rate dropped from, orthostatic heart rates dropped from over 30 down to 16 or 15, which is normal, right? Saline works acutely. It's great acutely. Normal saline. Almost everyone feels better acutely. The problem is giving it chronically. Now, there's a recent paper from Blair Grubb's group where he found that chronic saline helped as well. The important thing about Blair's paper is that in this cohort, in most patients, they stuck to using peripheral IVs. And patients were on therapy for a controlled period of time in most cases, 3 to 6 months. In that time, they tried to get them to exercise and do other things to get them off this therapy. If they don't do that, they end up on central lines. And the problem with central lines are the central lines. It's not the saline usually, it's the access. And we don't need to run through the litany of all the bad things that can happen. They're usually infections I can't pronounce, pulmonary embolism, SVC obstruction, it's bad things. Not the majority of people, but at a higher rate for potentially life-threatening complications than I usually find acceptable for what is otherwise a non-life-threatening but debilitating disorder. We did some data looking at DDAVP, so desmopressin. This is a drug that we give 5-year-old boys that wet their bed. Right? How bad can it be? And we found that with water, that actually lowered the heart rate in POTS. That's great. The one thing to be careful about is we don't tell 5-year-old boys at night to drink lots of free water, right? So there's a real risk that you can cause hyponatremia. So I use it as a special event drug. If someone wants to go to a movie on Thursday night and not sure how they'll feel, if they take this and water, they'll often feel better for a few hours. Blair Grubb actually set up something like a Coumadin clinic where he has people take it nightly and then checks, has the sodium checked weekly and it comes back and a nurse just looks at it, makes sure it's okay. And he tells me that he's only had a problem with one patient. Everyone else is fine. And this one patient thought, man, if 0.1 milligrams is good, 0.4 is even better. And she did get hyponatremic. So you just have to be careful with that, but it's generally fairly safe. A couple of final words on hemodynamic agents. So some are listed here. There are sort of more that we can talk about at some point. In terms of mitidrine, old data that it helps. Same control data as before. Mitidrine lower the heart rate, but marginal compared to the saline. The volume is much better. But again, as a chronic therapy, it can be very helpful. Beta blockers, controversial. I'm a big fan if you use it well. Others argue it's stupid. We did some, we couldn't figure out why people come to us at Vanderbilt and tell us they don't tolerate beta blockers, and we give it as part of our acute study format that you've seen before, and typically they do really well. And so what we found is that 20 milligrams of propranolol, which is the dose we use, lowered orthostatic tachycardia and improved symptoms. So great. But then we tested it against a full dose of beta blockers. So this is low-dose beta blockade. And at the higher doses, the symptom improvement starts to go away. So the key to beta blockers are not to control the heart rate or normalize it, is to take the edge off the heart rate increases, to use a little bit. If you use too much, you'll tire patients out and they'll hate you, right? So you need to find that balance. Acetylcholinesterase inhibitors, so this is Mestinon, the rationale here. The bottom line is we described that it both lowers heart rate a little bit, and does improve symptoms. Blair's published a larger series, that gives us some data that about 20% don't tolerate it, and these are almost all patients that have diarrhea predominant IBS, because that's the main side effect that stops use. So if they have constipation, they'll love it, because may help their tachycardia, it'll help their constipation. The final drug I think we're talking about is going to be norepinephrine transporter inhibitors, right, or SNRI drugs, or atomoxetine. So every drug we've studied, for the most part, lowers heart rate over time, because that's part of the design of the study. Placebo lowers heart rate over time. Atomoxetine doesn't. So atomoxetine blocks the norepinephrine transporter. It worsened tachycardia, both standing and seated. It worsened orthostatic tachycardia, and it worsened symptoms. Now, this probably isn't everyone. There's some people that tolerate these drugs. That's part of why we're doing this study, to understand the variability. But 2/3 of the patients reported a worsening of symptoms in the group that we studied. So the final thing that I'll say is don't forget about the rest of the patient, right? Everything I've said is focused on sort of fixing their physiology, and that's part of what needs to be done. But these patients are suffering a chronic illness, and they probably will continue to suffer chronic illness, and they need to learn to survive and cope and live with a chronic illness. There are different ways of doing that, but acknowledge it, because if you don't, they still won't get better. So just finishing with our patients, the list of drugs that we tried were there. She didn't tolerate some of the standard ones. She did well on a little bit of propranolol and salt. I have a theory that Yaz is bad because it's an analog of spironolactone, or an anti-aldosterone. Thankfully, the lawyers have pretty much gotten rid of it for other reasons. Got DDAVP once in a while, but basically she still wasn't able to work because of brain fog, and set up a home business. So take-home messages: POTS is a chronic disorder that's associated with a lot of disability. It's not a thing. It's a bunch of things. It's a grouping of a bunch of things. And the treatment critically involves exercise as a component, and then in various combinations, volume expansion some way or the other, heart rate control some way or the other, and then helping the patient live with it some way or the other. Thank you.